Hello friends, today we are going to discuss pulmonary embolism. Pulmonary embolism is obstruction of a pulmonary artery by a thrombus or a blood clot which usually originates from the deep veins of the legs or pelvis, that is deep vein thrombosis. Now, what are the causes of pulmonary embolism? So first, fat embolism, which can occur after long bone fractures. Then air embolism, which can occur due to trauma or surgery. Then amniotic fluid embolism, which can take place during labor or postpartum. Then septic embolism, which can take place in infective endocarditis. And then tumor embolism, which is a rare entity. Now, coming to pathophysiology of pulmonary embolism. So, the thrombus usually originates from the veins of lower limb and pelvis. So, embolism of thrombus takes place from deep veins. This embolism of thrombus causes obstruction in the pulmonary artery, which increases pulmonary vascular resistance, due to which there is increase in right ventricular afterload. This increases right ventricular strain. It results in decreased LV filling, thereby reducing cardiac output and hypotension. And if pulmonary embolism is massive, then it may lead to sudden cardiac death. It will also lead to ventilation perfusion mismatch, hypoxemia, and dyspnea. Now, coming to Virchow's trad. So, first component of Virchow's trad is venous stasis. Venous stasis occurs in immobilization or paralysis. Second component of Virchow's trad is endothelial injury, which can take place in trauma or surgery. Third, hypercoagulability, which can occur in pregnancy or patients who are on OCPs. Now, we will go through the causes of pulmonary embolism. Number one, trauma due to surgery. Then second, hypercoagulable state, example pregnancy, thrombophilia, OCPs, cancer. Number three, reduced blood flow. Reduced blood flow. For example, in cases of prolonged immobilization, then obesity and old age, patients with sepsis, where it can lead to endothelial injury, inherited thrombophilias. For example, factor 5 Leiden mutation, antithrombin 3 deficiency, protein S, protein C deficiency, sickle cell anemia. Now, we will go through clinical features of a patient with pulmonary embolism. Patient with pulmonary embolism can develop symptoms such as acute onset dyspnea, that is shortness of breath. Patient may also complain of pleuritic chest pain. Patient can develop cough or at times hemoptysis. And if pulmonary embolism is massive, then patient may develop syncope. Now, coming to signs in a patient with pulmonary embolism, patient will have tachycardia, tachypnea, hypotension, raised GVP, loud P2, and cyanosis. Now, we will go through classification of pulmonary embolism. Pulmonary embolism can be classified into low risk pulmonary embolism, submassive pulmonary embolism, or massive pulmonary embolism. Coming to low risk pulmonary embolism first. Now, in this category, patient has stable vitals and no RV dysfunction. Now, coming to submassive pulmonary embolism. Here, patient is hemodynamically stable, but there is RV dysfunction, right ventricular dysfunction. Right ventricular strain is present. Now, coming to third category, that is massive pulmonary embolism. In this category, patient has already developed hypotension or shock along with RV dysfunction or RV strain. Thank you.